Hello, my name is Richard Schulich, and what I'd like to present is progress in pancreatic cancer and the role of vascular resection. These are my disclosures. I think all of us know that pancreatic cancer is a very deadly disease. In the United States, it's actually the #3 cancer killer now. And I'm sure in Chile, it is taking too many lives. Unlike some of the other cancers, the incidence and death rate is still going up in the United States. And I'm sure that is the same trend here in Chile. These are the two main operations for a lesion in the tail. We do a distal pancreatectomy and splenectomy. And obviously for a lesion in the head, we do a pancreaticoduodenectomy. This is a paper that I published about 15 years ago with the Hopkins group showing that, yes, we did make progress over the decades from the 1970s, 80s, 90s, and 2000s, but not a lot of progress. And the asymptote reached here seemed to be stuck in stone. But what I'd like to show you is in the last decade, we've actually made a lot of progress. So what do we really have to accomplish in the next decade to further these areas of progress? We need a better understanding of the molecular events and impaired pathways leading to disease. We need to prevent pancreas cancer. We need earlier detection. We need more systemic therapies, and we need to take care of our patients in a multidisciplinary fashion. I'll show you some data on our laparoscopic approach, which we use in a minority of our pancreas cancer patients. This is Bert Vogelstein. He's perhaps one of the most famous scientists in the world. He works at Johns Hopkins. And in this study, he did sequencing of 24 pancreatic cancer specimens that I and the rest of the team removed from our patients. We were hoping to find only a couple of genetic changes in these patients, but what we did find is actually that there were many genetic changes. And you can see in this patient, there were over 150 genetic changes, and the lowest number was in the 30s, and that every patient looks pretty much different. So there was going to be no magic bullet and no one way of treating these patients. And what we learned was pancreatic cancer is really hundreds of different diseases, depending on the genetic changes. But one area where this has led to some good results is that we know that patients with pancreatic cancer with BRCA mutations are actually great responders to platinum-based and PARP inhibitor-based therapies. And you can see this is a graph showing the relationship between BRCA mutation and response to platinum and PARP inhibitors. So when we have a patient in clinic with a BRCA mutation who has pancreatic cancer, we actually go to these therapies sooner rather than later. Another thing that we have learned over the past few decades are the risk factors. So if everyone stopped smoking in the world, about 1/3 of all pancreatic cancers would disappear. And that is a significant number of people with pancreatic cancer. But we know the other risk factors include obesity, poor diet, family history, and diabetes. This is work done by Gloria Peterson showing odds ratios of developing pancreatic cancer. And you can see there's definitely a linkage between smoking and longstanding diabetes. And you can see that the odds ratio increases almost sixfold. We know that pancreatic cancer, like colon cancer and like many other mucosal cancers, form gradually over time and through a series of genetic changes. And this cartoon here summarizes some of the key genetic changes that are found commonly in all pancreatic cancer patients. And you can see that with this process, evolution of pancreatic cancer, there may be opportunities where we can pick up some of these genetic changes early and actually find which patients will develop pancreatic cancer or which ones have developed pancreatic cancer and perhaps catch them at an early stage. And this brings up the concept of possible liquid biopsy for pancreatic cancer. So with a liquid biopsy, unlike a traditional biopsy, we actually take blood from a peripheral vein and analyze it for circulating tumor cells. We look at the DNA and RNA fragments and specifically focus in on exosomes, which tend to have a lot of these genetic materials that may signal a potential cancer or an existing cancer within the patient. This is very different from the traditional biopsy where you have to suspect a mass, put a needle directly into it, and through an invasive procedure, sample. And I think the liquid biopsy technique has a lot of promise, but it's still in development. Another potential area that we could intervene is that we know that some pancreatic cancers develop in patients with certain types of cysts. And I put up in this cartoon here the major cysts that we find in our patients when we go to clinic. And some of these do not have malignant potential, such as serous neoplasms and pseudocysts, but mucinous cystic neoplasms and intraductal papillary mucinous neoplasms, these do have malignant potential. And in fact, of the IPMNs, the main duct variant has a very high propensity for developing into a cancer, whereas the side branch type of IPMN has less of a propensity, but there are definitely risk factors that warn us when a side branch IPMN may be dangerous. This is from the European study group led by Marco Del Chiaro, who's a pancreatic surgeon now, who is at the University of Colorado. He's chief of surgical oncology. But he and the rest of the group have developed an algorithm to study patients with cysts found in their pancreas and to try to decide which ones may be dangerous and which ones are not. I won't go through this in detail, but you can go ahead and look this paper up if you have interest. This is a study that I participated in with Mimi Canto at Johns Hopkins, where we took subjects who had a strong family history of pancreatic cancer. Typically, they had 2 or more first-degree relatives with pancreatic cancer, and we followed them. And the bottom line from this was that if we followed them and we intervened, but they didn't have cancer, then obviously they did very well. If during surveillance they did form a cancer, their survival was much better than those patients who elected not to be followed in our surveillance program but developed pancreatic cancer. And there's quite a spread between these two lines. The other thing that I want to update you on is that there are a lot of clinical trials now that are studying pancreatic cancer. I did this about 2 weeks ago, and I looked up how many clinical trials in the NCI database there were, and there were 352 active clinical trials that were studying pancreatic cancer. So I am sure that in the next 5 and 10 years, the results of a lot of these clinical trials will really inform new methodologies and new techniques for dealing with pancreatic cancer. So whatever improvements we have now, I'm sure we will have more in the next 5, 10, 15 years. This was a landmark study that showed that when patients were treated with FOLFIRINOX, in addition to a curative intent resection, that they did much better than the standard chemotherapy that was given before, which is gemcitabine. And you can see in this clinical trial that the 5-year survival rate was much higher than you saw historically, and that the median survival was actually quite good. And I think FOLFIRINOX is really a mainstay of treatment now for patients with pancreatic cancer, and we certainly use it very often in our cancer center and in our department of surgery. In addition to traditional chemotherapy, a lot of work has been done on immunotherapy. And I just bring this up as an example that's being developed here at the University of Colorado. This is Yuan Zhu, who is in the surgical oncology division. He is a basic science researcher, and he has discovered a new pathway which, if we interfere with, may increase the ability of our immune cells to detect pancreas cancers and other cancers and basically eradicate them. And this was a paper that was put out by our group. And I won't go into the very specific scientific details of this, but we are now working with drug companies to develop this for human use, and look forward to presenting more information as this develops. Another area of really, I think, great advancement is taking patients with borderline resectable, or even what were traditionally called unresectable cancers, and successfully resecting them of their tumors. This is a panel that I participated on, defining what borderline resectable was in terms of metastases, venous involvement, and arterial involvement. And what we have learned over the past decade or so is, yes, T-stage has some importance, but it actually does not have a lot of importance in terms of long-term survival. So as long as you can resect these patients, then that was really all that mattered. And it didn't matter whether it was T1, T2, or T3, they had the same long-term survival rates as long as you could get the cancer out. The other thing about pancreatic cancer is we're very focused on the CAT scan and the involvement of the main vessels, but really pancreas cancer is very often a systemic disease. So it requires some combination of taking out the local tumor, but also systemic treatment with combination therapies such as FOLFIRINOX. This is actually a study that came from the Johns Hopkins group, and they found that in 136 resectable pancreas cancer patients, that 96% of them had detectable circulating tumor cells. And what this tells you is that, yes, we are very focused on the local involvement, but it is very important to pay attention to the systemic therapy, and to make sure that beyond just the surgical approach, the technical surgical approach, that we are treating these patients in systemic fashion. This is a very important study from Christina Ferroni from the Massachusetts General Hospital that shows that the radiologic studies actually very often look like there's no change after treating patients with FOLFIRINOX. And what happens here is that although the CAT scans don't change after a couple months of FOLFIRINOX, that despite how the imaging looks, that many of these patients can be taken to the operating room to have an R0 resection. So I just want to get into some of the specifics here. With venous involvement from pancreas cancer, we avoid prosthetic grafts. The reconstruction should have no tension. There should be no kinking. We should avoid interposition grafts, and we don't need to implant every branch. The cornerstone of doing these resections is doing a Cattell-Brash maneuver, and we typically use an artery first approach. So with a Cattell-Brash, we move everything over to the left side, expose the root of the SMA. And this is just showing an artery first approach. Here's the involvement of the vein. And of course, after you get to this stage, we can just simply cut it here and cut it here and dissect. And this is basically that same case where we had to resect a piece of the hepatic artery and also a portal vein resection to get that tumor out. And that shows it nicely in this picture and in this photograph. The other thing that we've learned is you don't have to implant every jejunal branch. So in a tumor that looked like this, we actually just implanted one branch here. This is the splenic vein. This is the IMV here. And this is basically the ileocolic branch. And this was enough flow back to the liver, and this patient did extremely well. So you don't have to reimplant every jejunal branch that you come across that's involved by the cancer. In terms of the artery, for arterial dissection and reconstructions, we avoid radiation, we avoid prosthetic grafts, we consider total pancreatectomy, we use antibiotics and antimycotics, we sometimes use heparin and aspirin, we avoid epidural anesthesia because sometimes we have to anticoagulate, and also it leads to hypotension. And we always try to dissect arteries out first, and sometimes we plan on an arterial resection, but we don't have to because actually the arteries dissect, and we use frozen sections to help guide us in that area. So again, this is a very ugly CAT scan. that shows involvement of the hepatic artery. But this is what things look like after dissection, and we were actually able to dissect the hepatic artery. Here's another case where that looks actually quite similar, and in this case, we couldn't dissect the hepatic artery, and we had to do a resection of the hepatic artery and reanastomosis right there. So, and you can see that. In this case, we actually had to do a portal vein and SMV resection. This patient had variant anatomy where the hepatic artery came off the SMA, so we took advantage of that. And I think in many cases, there is variant anatomy. Another technique that we use is arterial rotation. So this is a splenic artery rotation to reconstruct the left hepatic artery, and this is a middle colic artery to reconstruct the right hepatic artery. So sometimes we use existing arteries and reconstruct. And this is, again, an example of both an SMA and SMV resection and reconstruction, locally advanced tumor, resection here, reanastomosis, and resection of the SMA and anastomosis. So what are the risks of doing an arterial resection? Well, there are definitely increased risks. And in this paper, we actually compared some of the results of the Mayo Clinic to ours. And I'm sorry, this thing keeps advancing on its own. But you could see that in this group of patients, they had a lot of pancreatic fistulas. They didn't do total pancreatectomies. They used prosthetic grafts, and they used radiotherapy. Whereas this paper from Marco Del Piero had the opposite, and you can see the operative mortality rate was a lot less in doing this. So we have actually gone to a multidisciplinary care model here at the University of Colorado, where all the patients come in on Tuesday, and we discuss these patients, and we go meet them together. And through this multidisciplinary model, we've actually been able to grow our pancreatic resection margins quite significantly. And the other thing we found is very often we disagree with the opinion that these patients were given at the outside clinics. And almost in a third of the cases, we do something different to what was originally recommended. In the next minute or so, I'll show you some of our results from minimally invasive surgery, laparoscopic pancreatic duodenectomies. I think most of you understand the pros and cons of a laparoscopic approach. And this video, I'm not going to show it in its entirety, but this just focuses on the pancreatic jejunostomy portion. And I just put it in there because many of you are surgeons and you enjoy seeing videos. But because of timing today, I'm not going to show very much of this. This is the pancreatic jejunostomy portion. This is a V-lock suture, which is barbed, and this is the posterior outer layer. So our laparoscopic anastomosis is very similar to our open anastomosis. It's a ductal mucosa anastomosis with 2 layers, and we typically reconstruct with a stent. And again, because of time, I can't show this video. These are our results. We compared our early series to our later series. These are the specific data, but the next slide actually has it in graphical form, which is easier, I think, to understand. So there's definitely a learning curve in laparoscopic pancreatic duodenectomy. You can see we had complications in the first 50 patients, and this rate was much lower in the next 40 patients. Luckily and thankfully, we did not have any operative mortalities in these laparoscopic pancreatic duodenectomy patients. So in summary, pancreatic cancer is deadly. It can be performed with low mortality, but the morbidity rate is high. Best results are at high volume centers. We talked about all these different areas to work on to impact survival. And I showed you some information on our laparoscopic pancreatic duodenectomy program. This is a picture of our University of Colorado Medical Center. These are the mountains in the background, the Rocky Mountains. This is a very dynamic campus, and it's always growing, and it's really a great place to work. This is what we do in the wintertime here at the University of Colorado when we're not in the operating room or in the research labs discovering things. We go skiing and we participate in the mountain sports. This is what Denver looks like in the summer. It's a very, very beautiful city, and the weather here is spectacular. This is what I like to do in the summertime, go fishing. The other thing is US News and World Report ranks the best cities to live in the United States. And Colorado took 4 out of the 5 best cities to live in the United States. And Denver is number 2 on this US News and World Report ranking. So we're very proud of that also. Thank you very much for your attention.